So in all full transparency, my clinical interest and background is really in the area of urologic oncology, mostly prostate cancer. I sort of met Mo and Marty, gosh, I guess it's been about 10 years, as urologists, especially those in the oncology world, started really getting involved. And we did some of the early trials back in 2000 relative to the effects then of we were studying rank ligand inhibition. So that sort of actually developed the early in independent urology practices. It was the development of bone health clinics that actually led to the ultimate proliferation of advanced therapeutic centers that we see a bit now that have developed in large independent practices. So Marty called me a few months ago and said, hey, can you talk a little bit about testosterone replacement and really talking about this TRAVERSE study? So again, it's not sort of the literature that I keep up with per se, so, but I appreciate the opportunity. Let's see here. So these are my disclosures. So I'm going to spend a little bit of time on this. You know, the bone to me has always been a very interesting organ, and it is an organ, and just like any other organ, it is constantly remodeling. You know, I trained back in the 80s at Vanderbilt, and this was in the pre-LHRH analog days, and it was, you know, a couple things always stood out to me. Number one, you always had these patients, these widely metastatic prostate cancer patients that came in with super scans and were completely asymptomatic. So that was one area. It's like, how can this actually be? And then the other phenomena, again, probably not seen as much, is that I remember doing bilateral orchiectomies in the VA in patients with a widely metastatic disease, significant pain. You do a bilateral orc, and literally within 2 hours, they are completely asymptomatic. So the bone, you know, really back in the earlier days, very interesting organ. Probably the guy that does the most work, really does great work on it, is Ken Pienta over at Johns Hopkins. But this is sort of what we know about bone remodeling. And again, it is a constant turnover, and it's constantly remodeling. And really a lot of it is driven by rank ligand. So rank is produced by the osteoblast. It actually has what we call a decoy receptor that allows it to sort of not stay active, but then ultimately rank will bind to the osteoclast, and the osteoclasts are really it's a constant interplay between bone formation and then bone resorption. So back in the 2000s, when again, as standard of care, as all of you know, for advanced prostate cancer has always been basically driving testosterone as low as we can, we fundamentally came to the realization that number one, there are significant side effects associated with androgen deprivation therapy. So that actually is what catapulted many of us to try to understand the area of bone resorption. And in the 2000s, really the only drugs that were available were basically zoledronic acid, which we used, which required an IV, required creatinine clearance. And then in the mid-2000s, we started working with Amgen on their trials using denosumab. So right now, patients on androgen deprivation therapy in advanced prostate cancer, all of us continue to use androgen deprivation therapy with supplemental therapies. So this has really formed our basis. So when Marty called me and said, hey, can you talk about this fracture rate in this TRAVERSE trial? So, you know, obviously, like Mo had just pointed out, large trial, 5,000 plus patients, double-blind, placebo-controlled, designed to look for cardiovascular safety. But what they determined was, what they found is that there was an increase in the total number of fractures. So a secondary trial was actually then was this fracture trial, which is really a subset of the patients within TRAVERSE. So when you look at the fracture trial, and I'm going to kind of just summarize this for you, basically what we saw is that the total number of fractures in the trial was higher in the testosterone replacement group. There were 186 total fractures in the testosterone therapy group versus only 123 in the placebo group. So that's sort of what was completely unexpected. Now, when you start really breaking it down, I think the things that you need to look at is that, number one, most of the fractures in Table 2, when you look at it, most of the fractures in this trial were actually from a fall. The majority of fractures were from a fall. There were very few spontaneous fractures, and when you look at the type of fracture, actually, most of the fractures that they observed actually were in. Let's see. Sorry, I'm having a little problems here. Most of the fractures that were observed were in the wrists, ribs, ankles, and again, those are common fracture sites that we see in osteoporotic men. But then when you also look at the cohort and the demography of the patients, you had a very overweight population based upon, as noted in their body mass index. 2/3 are diabetic. Traverse, again, was designed to look at cardiovascular endpoints, not necessarily bone fractures. And again, there was no data on baseline, which actually we're trying to gather this quite a bit in our advanced prostate cancer clinics, on exercise or bone mineral density. A lot of them didn't have DEXA scans at entry into the trial. So again, increased number of total fractures, but the fractures that we're seeing, many of them that were in wrist, ribs, ankles, again, those are what we see commonly in osteoporotic men, and many of the fractures that were observed were directly related to a fall. So when I started looking at this and I was trying to figure out, okay, what's the incidence in general of osteoporosis? So this was a very interesting trial, single institution that Ravi Cocker and Abe and some other people looked at. And so this was a single institution trial, about 400 men who were basically being evaluated for an infertility clinic. And what they found, there's a couple key points here. Number one, about close to 40% of men, all under the age of 50, had evidence, mostly of osteoporosis, osteopenia as well as osteoporosis. That's at baseline. So that's a significant number. And then when you looked at the patients then, because many of these patients, again, were being seen in an infertility clinic, when you looked at there were 75 patients actually in the testosterone group. They then had a follow-up bone mineral density scan, had a DEXA scan, and what they found is that those patients that underwent testosterone replacement therapy actually had a significant increase in bone mineral density in the spine. Not at the hip, but at the spine. And as you might expect, for those patients on estrogen modulators, they had a decrease in bone mineral density. So again, every time, to me, what the significance of this trial is a couple things. Number one, you have a significant incidence in healthy men less than the age of 50 that have evidence of osteopenia and osteoporosis. However, with testosterone, you can definitely see an increase in spine BMD, which again may result in a decreased fracture rate. Obviously, the limitations of this trial: small number of patients, retrospective, single institution. So as I look at all this is kind of what I've come up with. I think the result of the fracture trial, which is a small subset of Traverse, shows an increased risk of absolute number of events, but entry for the study was to look at cardiovascular events, not bone events. Existing data suggests that the incidence of bone mineral density loss is significant in healthy men, and I believe that, again, when you look at this trial, Traverse, there are clear benefits beyond bone health in which I think testosterone replacement therapy has its benefits. Thanks.